You're listening to the Medic Materials Podcast, hosted by Mike Turek, a paramedic and educator with over 10 years' experience. Every month we review actual EMS calls with the help of current practicing EMS providers, bringing educational opportunities directly to the listener. Portions of the calls have been altered to protect the privacy and identity of those involved.
Hello and welcome everybody back to the Medic Materials Podcast. I am Mike Turek and I'm here with Gerard, the New York State paramedic, as always. I think you've been now in every single episode.
Every single
we
one.
are going to make sure.
I have nothing better to do.
But
my life is so empty and dry.
We love you here. I love you. Your opinions. It's great. It's great having you.
I left my soapbox at home.
That's probably a good thing. And secondly, we are joined again, second month in a row, with Emily, the nurse / EMT that did a phenomenal job last podcast. So hopefully you guys hit like the follow thing, because that's what I would have done. So this episode's going to be a little different, though. We're not introducing a call for review. I'm sure a lot of calls are going to come up. Lots of stories are going to come up, but we're going to have a general conversation this time. And we want to hit the topic, a overall generic topic, of when to pull the trigger and when to not pull that trigger in EMS. And we're going to talk different circumstances, different, skill sets and different things that maybe you've come to a decision, a crossroads, where you're sitting there as a paramedic or EMT, seasoned or new, and you're left with the decision of, do I intubate this person? Do I not intubate this person? Do I call for ALS? Do I not call for ALS? Do I use the IO gun? Do I not use the IO gun? And you're sitting there weighing the benefits and the risks, going, do I not? So that's what we kind of want to talk about, and we're kind of doing a round robin here, and I think it'll just be a generalized, interesting discussion for, like I said, new and seasoned providers who have been in this situation, as we all have. Like, these are real situations that all three of us have been in, where we're like, should we or shouldn't we? And it's funny, the one thing that I remember the most out of my paramedic internship, other than my father-in-law telling me that we all suck, and Gerard can... Oh, you were there for that conversation.
I was part of that. Yes.
It was that will live
in infamy.
Until the day I will be telling EMT students until the day I die. You all suck. And believe me, I'm trying to get him on here to tell you exactly what the thought process is behind we all suck. So hopefully he gets the courage and wants to talk to everybody. But the other thing that I learned was the analogy of, as a paramedic and even as an EMT, you have all of these tools at your disposal. And you have to understand that, it's like firing a firearm, right? Yeah. You have all these different types of ammunitions, and you say, okay, I'm going to use this ammunition, I'm going to load it up, and boom, I'm going to use it. I'm going to fire that. But you have to be prepared for what that ammunition does after you've fired it, after you've pulled that trigger. Is it going to do benefits? Is it going to do bad things? What do I have to look for down the road? Or is it worthwhile just to sit and do nothing, right? Sit on my hands. And sometimes that's the best, and we'll go over that. Sometimes it's the best thing is just to sit there and monitor your patient. So, Gerard, you had an interesting one that literally just happened. Yeah. So it's fresh in our mind. You and I talked about it yesterday, but I think, going over it again, kind of in this benefit risk thing would be an interesting story to tell.
Yeah. So I had a critical patient having a cardiac event, and she's still alert and oriented. She's still speaking in full sentences, complete sentences, able to follow commands. She's, she's her. There's nothing abnormal about the way she's presenting as far as her mentation goes. But she's in a lot of pain, chest pain, and definitely needed to get to the hospital sooner rather than later.
Now, I think I'm going to cut in the benefit, or I guess not the benefit, but the the thing that we should outline is you say cardiac event, but it's a significant cardiac event, right? This is MI, myocardial infarction.
It was a STEMI.
Right, it's a STEMI. So we're up against time, right? Time is muscle in this. Time is heart muscle. It's infarcting at this point in time. So it's, a critical cardiac patient is, just backstory to
absolutely
to listeners.
Absolutely. And it was we arrive on scene, and according to the people there, it was we were there 20 minutes into the onset, so the clock is ticking. Now this is an individual who does not present. I'm just going to go and say it presents with absolutely zero points of vascular access.
I'm going to second that.
I'm going to look at Emily and I'm going to say she has no access. You couldn't get her.
Let's put it this way, and I know you have, because again, all three of us work at the same agency. We've all had this patient. I am notorious. You've watched me do it. I am notorious for weird placed IVs.
My favorite.
Love feet, love ankles, weird places.
Yeah.
I've tried nothing. So when he says zero access, I second that. There is zero access on this individual.
Believe me, I'm always one that gives the good college try.
Yeah.
And this was my second interaction with this patient, and the first time, again, gave it the college try, didn't work. Okay, she wasn't critical then. It was just let's just transport and go. It's okay. This time, we're talking, MI. We're very symptomatic. In my mind, I need access. I have to have access. Because, of course, I'm giving nitroglycerin. And I can honestly say this was the first time I've ever taken a patient into a hospital in this condition using that medication with absolutely zero vascular access. And it felt like I described to them, it was like walking on a tightrope, no safety net. I had nothing underneath me to save my ass if everything went south. And we all know we've had people where, hey, they're 200 on 100. Here, have a shot of nitro. Oh shit, they're 70 on 30.
Right, and and that's the big thing. Especially with a STEMI. Yeah. Depending on what kind of STEMI, sometimes you're thinking, oh, well, am I going to affect preload here? Right. Or am I going to affect afterload even? Tanking that pressure, and that's why New York State has the 120 rule. You cannot give nitro under 120 systolic, preventing that hypotensive reaction with the nitroglycerin due to that vasodilation. So,
but even the 120, I mean, I've literally had patients where they've been 160, 170. I think was the worst one, where 2 administrations of nitro later, and they were like 90 systolic.
Right.
And it was just like,
I've seen it.
Like, wow, where'd that come from?
Yep.
So, get in the ambulance. Said, all right, we're gonna give it a shot. We're gonna take one stab at this. I know anatomy well enough that I know there should be veins here. I can't feel them because of her anatomy, and just physically the way she is as a patient. Went in, no flash, nothing. When I realized that, once again, I was not going to be able to get an IV on this woman, the immediate thought was I should probably drill her. I should probably get the IO out, give her, give some kind of, pain medication or some kind of sedative, something along those lines. In this instance, I probably would have opted for fentanyl and just go ahead and pull the trigger and go ahead and get an IO on her. But having performed an IO on conscious patients before, again, that kind of weighed on my mind was it wasn't a very pleasant experience for those patients. So the fact that we were, having this event, she's already in a lot of chest pain, her anxiety levels through the roof. I said, hey, you know what? Let's just go. And as long as I keep seeing 120, BP is above 120 systolic, we're going to keep giving nitro. And if I have to deal with it, I'll deal with it at that time. Immediately following, I, walked out of the hospital and said, damn, that was stupid. I was tap dancing on a landmine. I should have freaking put that IO in. Because I walked her in with no access. And that was stupid on my part. So, yeah, when to pull that trigger, it's one of those places where it's just not black and white. Maybe to some people it is, but to me, it was in this big area of gray, and I'm not a gray person. So.
And I'm pretty sure EMS is all gray, and there is no black and white.
It's very hard for me to live in this because I'm a very black and white person. It either is or isn't. It's right and wrong. And
I'm trying to acclimate you.
Yeah, this grayness, I can't take it. But it was one of those. It's one of these where did it work out in the end? Yep, worked out great. Walked in and let the people with vein finders and
dude, those infrared vein finders are amazing.
You have no idea.
They are amazing.
You know what's even better? Ultrasound.
Yeah, that's what I was saying.
Eventually, EMS will have that.
No, they won't.
That trickery and magic that you do. So, to let them take care of it.
So if you had that exact call again, would you make the other decision? Would you drill her?
Yes, I would. Absolutely.
You would.
I think I would.
And
I know I would.
So she asked that follow up. I'm asking the why.
Yeah,
what was the like you and I had this conversation. So in you give yours and then I will give my perspective as the fellow paramedic here that.
So we were getting relief with the nitroglycerin. Initially, the systolic blood pressure was like 140 systolic. And after the first dose, she dropped 10 points. She went into the 130s. And then she got some relief, so we didn't have to give her another one for a little while. And then she said it was coming back, so I gave another one. And then we ended up in the 120s. And we pretty much stayed in the 120s. The lowest systolic was 122.
Mm-hmm.
And, in my head, I made a hard deck. If I see anything below 120 or a map of less than 65, or even at 65, then I would go ahead and perform the IO. But the reason I didn't, thinking back, having another day to think about it, honestly, I think it was the past experience with drilling a conscious patient. Most of the times, when we do IOs, they're unresponsive. That's why we're doing it. We just need quick and nasty access, cardiac arrest, things like that. Or nasty traumas where, hey, you know what? Just put one in real quick.
And
it was those it was the previous experience that thinking about it. Am I gonna I'm gonna put this one into more pain? The moment you mention anything about drill and bone.
I'm sure anxiety's going up, heart rate's going up, right?
She's already tacking away at like 125. I don't need her freaking out even more and becoming her own worst enemy. So I erred on, I guess, my
patient comfort.
Yeah,
and I don't think that's a bad way to look, right? You're looking at it from a perspective of not only patient comfort, but is this patient going to be better off or worse off after the fact? So, I've done, again, you lead me in IOs, but I've done my fair share where, yes, I've drilled the unconscious and I've drilled the conscious. Is it pleasant to get a drill bit into your tibial plateau and then get fluid pushed into your marrow space? No, it is not pleasant. But no one has ever tried to kick me in the face because I've done it. Right? So, it's unpleasant. It sucks. I get it. I feel bad for you when I go home.
Right.
But if you need it, you need it.
But let's go back and look at your specific patient on this specific call.
Right.
If you had done that, what kind of stress would that have put on the heart that's already infarcting? Would that have been worth it for a pressure that was still 120 or above systolic?
It's one of those things where
You're damned if you do, damned if you don't.
I know it's, especially with that particular patient's,
And I'm gonna
presence of mind at that time was, I'm not gonna mince words, but asking, making me, tell her, hey, don't let me die, and she's already going down that path of being her own worst enemy. But then thinking about it on this end of it, on the other end of it, yes, it would have maybe increased her level of anxiety. It would have definitely increased her level of pain at that time. I'm not so sure how, an IM injection, pre-drilling a fentanyl would have done. Remains to be seen. I haven't had much luck with it with larger people, but I do know after I would have had it, now I've got access. Now I can deliver pain management. I can deliver fluid. I can do everything I need to do, and then if something, I can manage her blood pressure. So I can give her more nitro because I can keep her BP up. And if she decided to go south on me, I'm already a step ahead of the game. So is the benefit in this case better to have done it? Looking back now, I probably should have.
And I'm gonna cut in to kind of go into that. Is it going to hurt the infarct further, with mentation and how she's going to, treat the trauma of the IO, because it's literally what it is. You're causing a piece of trauma.
We're doing harm to do no harm.
Right.
Yeah.
So I have to quote my Mainer uncle in "It's hard saying not knowing," right? Because you don't know. She could be completely fine, or she flips out and look, she went from 3 millimeters elevation to 6. Well, we're screwed. Right. It's hard saying not knowing, but you and I had the conversation, and I want to touch base on it because this is the big thing that was taught to me in the transition from EMT to intermediate, was the fact of BLS providers are taught to recognize this is bad. Let's get the fuck out of here and get to the hospital. Get to the paramedic, get out of here. Intermediates and paramedics are taught this is bad. Okay, let me stay here for a little bit. Focus in on what needs to be done to stabilize, then we'll get going.
Right.
So when you and I were talking about this the other day, it was in my thought process, I might have done at least the attempt for the IV in her room. Right. Instead of going 10 minutes and going down to the truck, try it in the room. Maybe you have success. Right? You're not losing any time. You're just doing it at a different place.
Right.
So then, because I personally, me being me as a paramedic, I do not give nitro ever without lines.
And I never have.
And I know you have until I've never done it, until this point in time.
Yeah, that was the first one, and that's why I was just uneasy the whole way in.
I would have been petrified. Every time the NIBP cuff would have blown up, I would have been like, "Oh, I'm screwed. She's gonna die right in front of me. Here we go,
dude." I used the example.
It's gonna be 30/12. Here it comes.
I used the example.
Roll the dice.
When I was talking about it with USI, I said I felt like every time I see the NIBP cycle, I felt like I was at Vegas.
Yep.
Like I'm sitting there waiting for sevens to come up. Snake eyes. Shit. You know?
And that's it. Like, so, do you take the extra time to try that crazy IV, put it in her thumb with a 24. I don't care. It's something. Believe me, I've done it.
Oh, I know, but as we know, with this particular person, there's nothing.
I know there is nothing, and that's tough. So me personally, I probably would have treated this one. Try the line. If I don't get the line, me personally, she's having a significant cardiac event where I have to do certain treatments to prevent a certain outcome.
Right.
She's getting drilled. And that's my opinion. I don't know if I would have been as nice and been like, yeah, maybe we'll, because
I unfortunately do have kind of like nice guy syndrome sometimes.
Sometimes
like
you do.
that.
But I would have explained it to her very nicely, but she probably still would have done it. Unless she outright said no. And then I'm like, well, hands tied, here you go.
If she were to refuse it, would you still give her the nitro?
No.
I don't think I necessarily would have changed anything that you had done.
No.
So I guess looking at it from, I'm going to be the nurse part of myself here. Being in a hospital, frequently we give nitro without access. Now that doesn't mean that we're not getting access, but I'm not waiting for that line to give the nitro to the patient complaining of chest pain.
Right.
Especially if they're having a cardiac event. Because we get EKGs very quickly, same as on the ambulance.
Right.
I have sent people to the cath lab without access.
Really? Okay.
Having nitro. As long as we're monitoring the pressure. Now, I'm not saying, I'm going to cycle that pressure every 20 minutes and call it a day. No, I'm probably going to do it every 3 minutes.
Mm-hmm.
So I absolutely have a pressure before. But if you think about the onset of nitro sublingually, which is what we're giving, correct?
Yeah.
The onset's what, 30 seconds to a minute?
Something like that, yeah.
Duration's 30 to 60. So in that time that you're going from the hospital, that one dose of nitro has already worn off.
Okay.
If her pressure maintained after the peak of that,
Yeah.
I would have given her another one.
Okay.
So I don't see the IO thing as I'm not giving nitro without access. However, when I was only on an ambulance, I had the same mindset. So it's just different past experiences play into your decisions now.
I think when you were explaining past experiences, I think that comes into play a lot.
It's huge.
Especially as field providers, we lean on past experience all the time. Like, hey, I've seen this, right? They might do this,
right.
Or they might do that. I'm going to be prepared, right? Because I've seen this before.
I know what's coming.
I know what's coming, right? I've seen that person bottom out in front of me with a cardiac event, so I'm going to withhold nitro.
And in this instance, I've seen, with both choices, facing me, I've seen the worst of both ends of it.
Right.
I've seen, inserting an IO into a conscious patient where, this person was already in excruciating pain, and they were in a lot more pain afterwards, we'll put it that way.
Mm-hmm.
That's something that you don't really forget because, we're not here to cause pain, we're here to take pain away.
Right.
But in order to take his pain away, I had to hurt him really bad.
Mm-hmm.
And I hurt him bad.
Right. And that is...
And that was in my head. But I've also had, looking at the other side of it, I've had people where, you're 160 systolic, here, have a shot of nitro.
Bottom
for your STEMI. And then all of a sudden I look back and they're 90 systolic. Right. Holy crap, what the hell just happened? What's wrong with you?
And
it's true.
And, I think, thinking about what I would have done in that situation, what I'm thinking, I don't like to be behind 8 balls.
Right.
Right? And that's how I would have felt. Right?
That's exactly how I felt.
The entire call, I would have been uneasy because I'm like, okay, I can give aspirin. I can give oxygen if the patient needs it. I can give pain management to decrease, the cardiac, need for oxygen, right?
Yeah.
Is the nitro really helping? Probably, right? Aspirin's the big one.
Oh, yeah.
Nitro just assists the aspirin. So I think in my mindset, if I'm behind the 8 ball, like, hey, if I don't have a line and she codes, well, fuck.
Yeah, that's one
right?
thing I have to do
I
now.
am well behind the 8 ball now, right? I got pads, I got CPR, I don't even have a line, I'm screwed.
Right.
You know, I think that would have pushed me past experience-wise to look and be like,
it takes one time to be behind the 8 ball on a call, and you'll never do it again.
And you'll never do it again.
Right.
You know, so I do think a lot of what we're going to discuss going around the table is what things in the back of our head make us choose, do we do it, do we not do it?
Yeah.
Here's past experience.
Yeah, and it's a combination of 2 past experiences that are stark contrast to each other,
Mm-hmm.
you know, that really drove my decision to sit on my hands,
Right.
basically. I mean,
You did all the other stuff.
Yeah, I mean, she got aspirin, she was getting oxygen. She was telling me that with the nitroglycerin there was relief from the pain. It was getting lesser and lesser. So I held off on any IM pain management. Maybe I could have.
And you're giving, here's the other thing.
I don't want to give a narcotic without IV access.
Yeah.
So,
well, and that's it too,
Yeah.
you know.
You know, so as long as she was getting relief, I kept, I guess rolling the dice, shall we say,
Mm-hmm.
that, she wasn't going to bottom out. We're going to maintain this pressure. We're gonna be okay.
Right.
We're gonna get her there, and I won't have to.
I'm just gonna, pinch my butt cheeks and hope.
but along the way, somewhere along the way, and I actually documented it that I did discuss that if things got worse and I had to, because she's well aware that her veins are not good.
I've had the same discussion with her,
and I basically explained to her what the IO procedure involved.
Mm-hmm.
And that I may have to do that.
Yep.
And but I also put the caveat that it's going to save your life. And she agrees. She says, "Yep, that you do what you got to do."
Yep.
And so that kind of made me feel a little bit better, because also I'm like, "Oh, thank you." All right, there's a load off. So
at least I'm half behind the 8 ball now.
If I do have to go that route, we already know what's coming.
Right.
It's not going to be a big surprise.
Yeah.
So. That kind of put me a little bit at ease, but I was still very leery. And I think along the trip, I delivered 5 doses of nitro on the way.
Mm-hmm.
So, I mean, we're talking, every time.
A fair amount.
Every time I'm going in there, I'm like, oh, please don't be the one,
Please let me pick the right slot machine today.
bar, cherry, shit.
So moving on from that past experience, I want to turn to you, Emily, because you were kind of brainstorming an interesting EMT related, decision making process here. So, and I think it's something that we all focus on. Do we call a medic? Do we not call a medic? But we don't ever focus on what you're going to talk about.
So I want to talk about, for all my lovely EMTs and medics out there, is when do we treat a patient with the tools that we have, and when do we wait for the medic to treat? I've hit this a bunch of times. I don't really have a specific story, but I've hit this a bunch of times where you show up on scene and, for example, you have a patient with chest pain. Am I going to give them aspirin and their own nitro now? Or is my medic that's 7 minutes away, am I going to wait for them? Maybe I'll give the aspirin and wait for the nitro. Maybe I'll do both. Maybe I won't do either. Maybe I'll work on x-ray, whatever the case may be. When do I decide that, nope, I'm going to treat this now, and when my medic gets here, he gets here?
Mm-hmm. And working now in a, EMT, EMTs are on their own, and, paramedic in the fly car type systems, mm-hmm. It's a big difference than what I've always been used to of EMT paramedic or double paramedic in one truck. So coming from that experience, there's a lot of times where I'm just like, I get there and I'm like, guys, why? Why didn't we meet 20 minutes that way?
Right. Yeah, why are you?
You don't have to
waiting for
cancel me. I'm willing to come. I want to come. Right? I'm bored sitting in the station, twiddling my thumbs, watching Netflix. I want to do something.
Right.
But why did you not start moving?
Right.
You know, do what you do. Meet me somewhere.
Right. We don't need to wait necessarily. We don't need to wait for a higher level care to come to scene. But it also plays a point. You made a point to say, if you're on a BLS agency and your medic's in the fly car versus you have a paramedic and an EMT on an ambulance, does that change your mind? So if me and you are on a scene for a chest pain, we'll keep with, am I going to give aspirin? Or am I just going to let you do it?
I'll just probably, knowing me, I'm going to hand it to you.
But as an EMT, if it wasn't just us,
I'm going to be rooting in the bag. Like, here, give this because I'm already getting out other stuff.
we can still do that. It's still within our protocols.
Right.
Just communicate. I'm going to say, like, I'm not one to stay and play. I'm not one to stay and play and wait for a medic, I should say.
Right.
I make it a game to try and race the medics off scene.
That's fun.
Catch up to me.
Right.
Not really. But I think it makes a point. A lot of times we'll be, as an EMT, we'll be on scene and I'll have my partners and they'll be like, oh, I'm going to call a medic. We'll just wait for them. We don't need to wait for them.
Yeah,
That's really not needed.
Well,
yeah, having worked in a fly car system before as a fly car medic, similar experience. One of the biggest frustrations for me was, showing up on scene and there's this 8-man BLS crew, from an all volunteer agency,
All standing there.
Oh, what do you got? Oh, we've got struggling to breathe for 3 days and they're turning blue and
they got a nasal cannula at 25 liters.
Right. So what have you done? Well, we've got a nasal cannula on them and we're giving them 3 liters per minute. It's like,
and we got the clipboard.
And the clipboard is ever present.
But don't worry, I have demos.
Right.
Right. I've got. Hey, you know what? Those are great.
Because the only demo I need is, ma'am, what's your name?
Yeah.
Mary? Okay, we're going to run with it, Mary. Let's go.
Honestly, you know what? I love it when they have all the patient information for me. Great. You save me a bunch of time and a bunch of stupid repetitive questions. That's great. I appreciate it. 8-man crew. 1 person can do that, no problem. You don't need all 8 to do that.
What are the other 7 doing?
One of the biggest frustrations was, showing up on scene, or there were times meeting for an intercept, and you get there, and it's like, okay, what have you done? Well, we got them on a nasal cannula at 3 liters. Oh, okay, but they're blue. Well, yeah, that's why we called you.
Right.
It's like, and at the time, you can't berate them. Well, I mean, I know some people do. I don't. I like, especially with volunteer agencies, they're doing it out of the kindness of their heart. They're coming out, all hours of the night and stuff. So I won't berate them on scene. I will curse their freaking name as soon as I leave. but I'll okay, thank you very much. Okay, thanks for the report. Okay, good, I'll take it from here and off we go. But yeah, it just seems like there's this EMT paralysis bug that, and I don't know, maybe people out there who live in and work in different states, maybe they have different experiences. But here in this state, it seems like the EMT has been beaten out of EMTs, and they have, been beaten to the point of, I am just a picker-upper ambulance driver.
Hold on though, because I'm gonna stick up for the EMTs. I've been on both ends of this, where I've been on scene, I've treated, and then I've had a medic show up and go up one side of me and down the other. So I understand
that's
it,
so
but
not right.
Yeah.
But I mean,
it happens. I get it, guys.
And working at agencies, I mean, honestly, let's be right, most agencies now that have EMT paramedics in the truck are very paramedic heavy with what can and can't be done, and EMTs are limited to
the bullshit.
Yeah, pretty much lift this and push on that.
Oh, you're gonna work on extrication and figure out, go get the stair chair,
right,
go get the
chair,
reeves, or go grab this. I'm a gopher.
Yeah, pretty much, and it's sad because that's what they've been relegated to. And being an EMT in one of those agencies, I've been there. As an EMT, I remember feeling completely useless because I know I could do more. I know I could do other things, but I guess I'll just go get the stair chair.
Well, and I think to unpack both of those, I think past experience, when I was an EMT eons ago, there were agencies that I worked for that, when I got hired, I was like, this is the kind of provider I am. I am in the shit, knee deep with my paramedic. We have a seizing patient. I am in the ALS bag, pulling out narcs, giving them to them. I'm not drawing them up. I'm handing them to him. But here's the needle with it. Here's the syringe with it. Like, I know what needs to be done. I'm going to help them, right? I'm getting this. I'm putting them on the monitor. I'm doing all that stuff. And they were like, you know what? That's awesome. We want you. But then on the flip side, I've been to agencies, interviewed, said the same thing. And they're like, nope, you're not even allowed in that bag. Right. You will not do anything like that. And I was like, sorry, I don't want to work here. Yeah. But one more point is you say there's a paralysis of EMTs. I think it's one step further in that there's a paralysis of EMTs, but this state and I think a lot of other states have made medics the savior. Mm-hmm. Right. And EMTs are conditioned to be like, I can't do this, but the medic is going to save me because they can.
And look at CPAP in New York State. I'm talking to all you New York State people. They just gave CPAP to BLS providers in New York State. But for years, this person needs CPAP, this person needs CPAP. We can recognize that, but it's, the medic's got to do it, so let's just call a medic. Yeah. Right. Before all of the skills that we have, now it's starting to roll out that we can do 12-lead BLS 12 leads. Yeah. We used to have to call a medic. Any chest pain had to call a medic because we need a 12-lead. Mm-hmm. So we're conditioned to that.
Right, and that is, you want to sit there and say we train the best, but you are paralyzing the people into a condition of, I'm sorry, the hospital's 12 minutes away,
or 5 minutes,
but I'm gonna wait 30 minutes for a medic to get here to do a 12 lead,
right.
Well, and to go along with what you were saying about, and to tell you what the biggest eye-opener was and also another thing that really helped me along my path of learning, when to pull the trigger on things and when not to, having worked at a system where, as an EMT, I was the EMT for, 15, 20 minutes until a paramedic could get there, and then also volunteering at a fire department where we were BLS first response, and I'm the EMT on scene until the BLS volunteer agency would show up, 20 minutes, 30 minutes, 45 minutes later, and then maybe a paramedic would show up, So a lot of those decisions, fell on my shoulders, and then, but to go along with what you were saying about, the medics going up one side and down the other, and it really does demoralize the EMTs to the point where they just, put their hands up and say, F it. And it was an eye-opener for me responding to a call with my fire department after being a paramedic for probably about 6 months or so. So I'd already been out there doing my thing. I was working at a very high call volume agency, so I may not have been there and done that, but I definitely had the T-shirt. And so
it still had creases in it from the plastic.
A little bit, but it was fresh off the rack. But I was wearing it, and and we had a chest pain call. The truck driver pulled off the side of the interstate. We show up on scene first. Unfortunately, our local ambulance couldn't get a crew together, so we ended up calling for an ALS unit from another town. I administered aspirin. I administered oxygen. Taking vitals. We didn't have nitro. He didn't have nitro, so I couldn't go down that route. But the ALS ambulance shows up. The crew jumps out. I start trying to give them a report. They, pretty much don't even want to hear it.
Who are you? Go away.
Until I say I've administered 324 of aspirin. Patient's on 6-liter nasal cannula at this time, because that's all he was saying, like 92, and I just bumped him up to like 98. And as soon as I said I administered 324 of aspirin about 10 minutes ago. Why did you administer the aspirin? You haven't gotten a 12 lead yet. Mm-hmm. You don't know what's going on. Mm-hmm. You don't know, and this dude literally berated me. Now, again, this is a great learning opportunity for all you paramedics out there who think you're gods and walk on water. When you respond to a BLS crew or a volunteer agency or anyone of lesser care, and that person, especially with volunteers, shows up and starts giving you a report, take the report, be courteous, be polite, be professional, and do your job. Because little did he know, I knew his effing boss.
Well,
who was a good friend of mine.
Right.
Well,
it's not even that.
Going up one side of me and down the other, he ended up having to stand tall before the man when he got back to his station.
Well, it's not even that, but
it's one of those things where, as if I was a brand new EMT, that would have set a tone.
Well, it sets a tone, but looking at that example specifically,
yeah,
I go onto a scene. You're my first responder.
Right.
I don't know that you're a paramedic.
Exactly.
That is working a full-time gig, doing 30 calls a week, and you're just volunteering as an EMT on the side.
Right.
Right? So who am I, big bad paramedic, to come in and be like, hey, Mr. CFR, you don't know a goddamn thing, when you and I are the exact same level.
Right.
And I want a shout out to the paramedics out here listening. Take a second and think, were they doing the best thing for the patient? Because for your specific example, you were treating the patient.
Right.
There was nothing wrong with her. So because he would have done it after a 12 lead, did that hurt the patient at all? Absolutely not.
No.
Right. Just because it might not, and it might not just be the way you do it.
Right. Doesn't mean it's wrong.
Is he literally standing over them, stabbing them in the head with a fork? Or is he treating the patient properly? Right.
So painful response.
His eyes are opening every time I stab him. So I want to turn it around and go back and say to you, Emily, what can you tell EMTs that are sitting here listening to this going, okay, well, she says wait, don't wait, but how do I make that decision? Where is the line in your opinion? What would make you wait, not wait?
So I'm going to look at the patient always. Is it a benefit to the patient to wait? Now, in my mind, I always say, is it a benefit to wait 10 minutes for a medic to get there? And then I think, what are they going to do that's going to make that better? What are they going to do that's going to make it worth it for their 10 minutes of muscle, of time, whatever the case may be? Time's the only thing that you cannot get back. Mm-hmm. So is it worth it to wait? Is it worth it to go and try and get maybe a different provider on the way? I do rural EMS, so I always have a decent transport time. Maybe the closest medic to me is coming from behind me, but I can get somebody out of the city or something. Mm-hmm. Maybe I'll play that part. But at the end of the day, what does your patient need?
Right. And I think, being... We kind of talked about this on last month's podcast, where you have to be confident in your BLS approach.
Correct.
Right? Mm-hmm. Your EMTs have to sit there and be confident that they actually know what they're doing and can make the decisions of, do I need a medic? No. Do I need a medic? Yes. This time's definitely yes. Even further, you said it the other day, do I need a chopper? Right? EMTs, firemen can call for a helicopter in our state. Now, granted, it might not be everywhere, but New York, a fireman, a policeman can call on their little ding-a-ling radio for a helicopter. Right? And my wife scoops down and goes, all right, what's going on?
Yeah.
Right? EMTs can do that.
Absolutely.
They don't need to wait 15 minutes for the paramedic. It's not an ALS skill.
You know how to assess a patient. You know if a patient needs, super duper care right effing now.
Right, and that's it, right? So we all evaluate patients.
Yeah.
And fundamentally, an ALS assessment, and Gerard and Emily are looking at me floating quotations in the air because... Yeah, we do some things a little different. Maybe we go in depth a little bit here or there.
It's still ABC, OPQRST sample.
But that's it. Yep. Fundamentally, a BLS exam and an ALS exam is the same thing. Mm-hmm. Yep. So if you have a rock solid approach to your, physical exam, you're finding all the same stuff.
Yep.
So why can't you make that decision? Does this
they
need...
They can make that decision.
They can. And they just need the confidence to do so.
They need to be confident that, hey, you know what? you earned the card. Nobody handed it to you, so you earned the right.
I mean, somebody handed it to them.
Well,
but they earned it.
But you did the work for that.
You did the work.
You did the work. Be proud of it.
Right.
It's a terrible joke. I'm sorry.
You earned the card. It is well within your scope of practice to assess a patient and call for the higher level of care. If that higher level of care comes in a helicopter, that's what it needs. Then that's what you do.
Yep. Yeah. I agree with all of that. And for any of the EMTs, seasoned or whatever, brand new card dripping, work on. Don't allow, if you're working in, a BLS agency, work with your partner to take turns doing stuff. Don't let one partner who's, say, more upfront personality do every assessment. Sit there and be like, yo, we're going to switch off. You can do this one. I'm doing this one, whatever. Especially do that with your paramedics. Every single time I'm with an EMT, they do the assessment. They walk in first because that's how I was. I want them to be like me when I was an EMT. So I tell them, listen, I'm going to go talk to the family. You figure out what's going on. If I need to jump in because it's bad, I'll jump in when I need to.
Right.
But most paramedics don't do that. They want to be the overbearing superheroes. And get humble, stop that. Yeah, it's the best thing that I can say.
There's literally times when I go on a call with one of my partners, and I'm just like, listen to what is going on while the EMT is talking to the patient, and I'm talking with a family member or whatever, getting more of a history, or if the patient's like a elderly or something like that. There's times I'm doing my stuff, and EMT comes back and says, this is what is going on, and I'm like,
all right.
And don't be afraid to ask questions. If I'm a new EMT and I'm doing an assessment, and then Turk's going to come and do an assessment, like, what did I miss? What did you find that I didn't? How can I do that?
Yep.
Right.
And I love that because I don't see everything. Yeah. My EMT sees 50% of the call.
Yeah.
Right? And in their mind, they're seeing 100% of the call. So they can see something. They can hear something. They could think of something that I never even think of because I'm sitting there looking at my conversation of in my head, do I IO this person? Do I not IO this person? Right. And they're like, dude, they're not even breathing. And I'm like, oh shit, I should do BLS before ALS, right? And so things are missed. So, we should probably listen to our, EMT cohorts.
Yeah, one thing I always tell like a new EMT partner or a new EMT, hey, if we're on a call and you feel like you're standing there and you don't know what to do, take the glucometer and get a freaking blood sugar. Just do it. Don't ask me if I want one. Just take it. Because chances are, I'm thinking of so many other things. Unless it's a diabetic, I'm not thinking about the blood sugar. So just
tell them to listen to lung sounds.
At the very, or listen to lung sounds. Do something like that. Do something. Just do something, simple, well within your scope of practice to do. You don't have to ask me whether or not to do it. Just do it.
Just do it. Any other things that you want to touch base on before we move on from now on? Do you think we hammered that one enough? Be confident.
I think so. Be confident.
I want to hear you.
You want to hear me?
Oh yeah.
Okay, so I'm going the airway route. Okay. So one of the things that I get pounded for by my lovely wife, because I love her to death, but as Emily said, she is the literal smartest person in the room,
hands down.
And she gets it from her dad. It's terrible. So, and both of them have made me feel like a half an inch big for this exact concept is when do we intubate someone, whether it be RSI or non-RSI, or bigger yet, and this is where they hammer it home with me, is post-cardiac arrest with ROSC. So do you intubate a ROSC patient or do you not? And I think we should touch base on both of those. So RSI, yes. RSI, no. Where are your limitations there? Like, what is the yep, this is getting it. Because you haven't done one, but you've been a part of many, right? Emily, you and I have done one together.
Yep.
You and I have done them separately. And there's always that fine line of, boom, we've exhausted all options, or you know what, this just accelerated enough where I'm done.
Again, with the concept of when to pull the trigger on something, it's very black and white when we have exhausted everything.
Right.
And then, okay, this is all we have left. Let's do that.
Right.
The patient stops breathing.
Right.
This is all we have. Yeah.
Yeah.
Right.
Here's the COPD here. We've given the albuterol Atrovent. We've given the Decadron. We've given Mag and maybe Epi.
Right.
We've given CPAP, and they still suck.
Right.
And we're like, well, what else do I got?
It's another story when it's, the patient's still breathing on their own, but there's that potential for the loss of airway. Emily and I were talking about a recent case she had in the emergency room where there was a potential for loss of airway. The airway was still there, but the potential was very high for it to not be there very much longer. And, when do you pull that trigger? You're like with me with the nitroglycerin, rolling the dice. That's not always a good thing to do.
And looking at it as rolling the dice, it's one thing to roll the dice with a blood pressure.
Right.
I can most likely
Airway's
get a blood pressure
different.
back.
Yes.
Yeah.
If I lose an airway, I've lost it. It's gone.
I agree.
And now they're dead because I ain't getting nothing back. Right? It's not like I can just open up their throat and be like, airway. Right. No, it's not. It ain't happening.
Right.
I find that for me specifically, I'm definitely much more aggressive when we're talking about an airway versus a line for the nitro. Like, you heard my opinion on that. Right. I'm not sure that I would have gone with the IO. Right. Neither here nor there. However, for airway, you cannot lose that airway.
And that's it. So, RSI, yes, is pretty cut and dry, right? Mm-hmm. Is it a head injury that they're becoming belligerent? Maybe it's an unsafe situation. Is it an airway issue or is it a safety issue?
Right.
If it's a safety issue for the crew and the person, yes, they're getting RSI'd, right? Could they last with no airway? Sure. They're maintaining, but it's a safety issue. So they're going to get RSI. Mm-hmm. Airway, the one you and I did, right?
Right.
She literally exhausted everything. She tired out. There was no reserve left. It was the only thing that we could do to keep her breathing. That's pretty cut and dry, right? With the ROSC patient, though, we come into the territory of they're still breathing on their own. There's no airway compromise. It's not swollen. There's no burns, right?
But there's a big butt.
But there's that big butt, right?
I cannot lie.
You didn't intubate during the cardiac arrest portion. Maybe it was such a quick ROSC that
you just got them right back.
Boom, right? They witnessed, boom, okay. Now, do you give them a paralytic and a sedative, maybe knock out their blood pressure that you've just gotten back, right? Because most people choose the wrong drugs.
Of course.
Yeah.
Because
it's a whole nother topic.
Because God forbid doctors still go, oh yeah, their blood pressure is 60/40. Let's use etomidate and sucks. Why are they coding, Mr. Attending? I don't know. Why did we use etomidate and sucks? Right? Literally, it happens, right? So
every day.
Doctors, paramedics, we use the wrong drugs because we suck, right? And we don't think things through. It's like one of my favorite childhood movies, Operation Dumbo Drop.
Guys like you don't think things through.
Guys like you don't think things through, right?
That's right.
So I'm so glad that I just...
quotes in front of her.
You are aging yourselves.
It was like made in 1996. Shut up.
You're aging yourselves.
So anyhow, Where is that threshold for post-cardiac arrest, ROSC situations where they have pulses, they're breathing on their own, they're breathing at a adequate rate, they have a good pulse ox, right? They're satting well on their own, maybe just a non-rebreather.
And we're going to make that decision to take it all away.
But now we're sitting there going, sucks to be you, dude. They're going to intubate you in the hospital. I'm going to intubate you right now. For the most part, unless I really feel like this is going to be a hinky airway, and yes, they're going to code in 3 minutes, I probably wait. But then there's the other side of the coin where my wife and her dad would be like, hell no, you don't wait. They are getting RSI'd on the spot.
Yeah, and I'm of that mindset as well. I mean, just the fact that they've already been in cardiac arrest. What do we know about people that have been in cardiac arrest? They like to go back into cardiac arrest.
It's such a beautiful place.
It's a nice place. The unicorns run by and the birds are chirping and all that good stuff. They can go to the light. It's a wonderful thing to do. But wow, I'm bad. but no, it is a tough decision. Even just RSIing, diff breathers and stuff. You're making a conscious decision to take a person's right to breathe away from them and say, I'm taking over your responsibility to be alive.
Right.
But in the ROSC situation, for me, it's would I have intubated them during the arrest after a couple of rounds? Yeah, absolutely. Oh, we got ROSC after one round of epi, a little pushy, and a
right.
shot.
You didn't get time.
Didn't have time to do the intubation. Well, guess what? I'm gonna do it now because this person, probably the first bump we hit going into the city we service, which has such lovely highways. They're paved with such pristine.
It's all right. You could say it.
Sorry,
It's
I can't
88 is terrible.
Yeah, it's garbage. But yeah, you hit that first bump, boom, back into arrest. Now what? Now I don't have my airway.
Right, and it's eye opening to me because my wife and her dad pretty much say the exact same thing, and I just harped on behind the 8 ball.
Yeah.
I'm literally putting myself
behind the 8 ball.
ball.
They cannot protect that airway.
Right. So it's an interest. Like, I'm not defending.
Yeah.
Don't do it because it's been made to the point where I've now started to. But it's an interesting theory because if I'm thinking about it, guaranteed another paramedic out there is thinking the exact same thing.
Absolutely.
Right?
And how long did education go? And it was BLS airways before ALS. You don't necessarily have to put an advanced airway in.
Right.
But how good are we at bagging?
Right.
Right? At least if they're on a vent with, good settings and it's not a freaking palm vent that you're blowing 550 at 16 into someone that's 96 pounds because that's the only setting on the damn thing. If you got a nice LTV, you got something that you can control stuff with.
Or honestly, let's face it, if you're a paramedic in a system like we are, where we have, paramedic EMT, eventually that EMT is going to be driving and you're going to be in the back by yourself. Honestly, the few that I've run in that instance, I just bag them myself because I know I can bag them better than that stupid little football can do it.
Oh, it's such a bad. I hate that freaking thing. I'm sure everyone out there, if you've used a palm vent football thing, you're like, oh, I hate that thing, Joe.
Yeah, they're garbage. But no, it was put to me this way, and this is why, because it was a question that had come up, I think when I was working out west, and I was originally of the mindset, well, hey, if they're breathing on their own, shit, let sleeping dogs lie. I don't
and that was my original mindset, right? They're breathing on their own, they're doing good, counting resps, it's good.
Well, and it was things. So I was working in a in an agency where we didn't have RSI, but we had a helicopter EMS crew based in the same town. So they're literally, a 2-minute ride from where we are. They have all the RSI capability. So it was, the discussion was, and they had never had a problem just, running out, jumping on our ambulances and doing things for us. So
I may or may not know exactly where you're talking.
you do know exactly what I'm talking about. So so that particular thing had come up, and before, of course, I was let the sleeping dog lie. Hey, we got that's great, and it was put to me that just think about it in simple terms. What is their GCS? Is it less than 8? What were you taught? Less than 8, intubate.
Yep.
Keep it simple, stupid.
And that's it. Don't overthink things.
Yep.
Here I am overthinking the most simple thing. Can an unresponsive person, because they're unresponsive,
Correct.
they're breathing on their own.
This isn't TV. This isn't 911,
right?
Texas or freaking first responders, whatever the heck show on
Sirens
TV.
is still the best.
Sirens is the best.
It's such a great show.
But this isn't where you push twice, you find some moron that will actually put their lips on somebody else's lips to blow into it, and then suddenly they rise like Jesus on the third day. And they're talking. No, it's not like that, and we all know that. So, yeah, if their GCS is not to the point of being able to protect an airway, then absolutely protect an airway.
You have to do it. Yeah. Yep. Now, would you just opinion question? Would you go full on RSI, or would you if they're unresponsive, try like a supraglottic device or something? If you have an OPA in and they don't have a gag reflex.
Right. If the OPA is already in, I'm going to go ahead and intubate, and then maybe do procedural sedation along the way if they start bucking.
Yep. I think that's a smart way of doing it.
If there's no gag reflex, why am I going to use paralytics and?
Well, and that's it. But some there's a mindset out there of especially in an RSI heavy environment. Like we are, not our agency specific, but our area is very RSI heavy.
For me,
I think a lot of people forget that you don't always have to use a paralytic.
Right. For me, RSI is something for, you're using that procedure for someone who is breathing on their own, is conscious, and we're gonna change that and make them unconscious,
right?
And we're gonna breathe for them.
Yep.
If someone's already unresponsive and they have no gag reflex, I don't need to paralyze them. I don't need to put sedation in. I can intubate. That's why so how we're taught on mannequins, right?
Yep.
But again, if you start getting resistance, they start chomping, or you go into laryngoscope and they start doing anything that you don't like or biting down, then we'll go to the RSI. But try it first without you don't need to go through all that rigmarole. Just
I agree. Anything, Dad?
No, I love it. I totally agree with that. You do not need to paralyze and sedate every single intubation you do.
And I totally wish more people would have that mindset, because I mean, like I said, there's places that are so RSI heavy. It's like
especially when you watch them and you see them choose the wrong drugs or maybe not the best ones for those patients, and you're just like, oh, what are we doing?
Yeah.
And I learned that from being at an agency that was very RSI heavy, and I would say that while I learned a lot of what to do, I learned a lot of what not to do.
Yeah, and I think
more when not to do things.
Well, and we started off today talking about past experience. It comes into a lot of our decision making. What did we see before? What did we see that went wrong before that we're going to do differently, right? Are we going to do more BLS before ALS? Are we going to, not, now that we've, established, hey, we didn't RSI or we didn't intubate these people, but now we've learned, hey, we probably should. So we're going to the next time, if we encounter that situation. It all comes down to past experience. And I think
in summation, I mean, that really is, I guess, the gist of what we've been getting at is your experiences, your past experiences, your level of experience is what's really going to dictate, whether or not you're going to pull that trigger for whatever that particular procedure or operation you're going to do. That's really probably the main driving force behind making those decisions.
Mm-hmm. And, experience is key. And, I've always feel bad for the providers that just don't gain the experience, whether they work in a slow system and they only do one job, in that system, or they're working with providers that are so overbearing that they're not allowed to have that experience. Get out, get your experience. I'm huge. I wish it was a law in this state that if you're a new EMT, you have to work commercial for a year.
Don't break my heart.
But the amount of experience that you gain, good, bad, and ugly,
learning bedside manner. I mean,
is phenomenal.
Manner, I probably wouldn't be where I am today if I didn't start off doing commercial EMS. Taking grandmas to their doctor appointments and stuff like that.
My saving grace is that I never work commercial. Ever. Never.
See, I started in commercial.
No, I do. Because they're in it. Well, I'm not even going to go.
Reason.
Yeah, exactly. But my thing is you also get into this you get out of this what you put into it. So put the effort in to educate yourself. Go and figure out the way to do this. You're not going to go through this without making mistakes. Learn from them. Don't pretend you're perfect.
Yeah.
Listen to a podcast. Read a book.
Or a YouTube channel. So is there... we'll just leave this as an open topic. Is there anything else that you guys can think of that you want to touch base on? Something else that might have been a, hairy decision, like, do we do this? Do we not do that?
Not about in the emergency room.
Oh, there's probably a million. I'm pre-hospitally right now. No, I think we just need to trust ourselves. If you're going to make a decision, stick to it, trust it, do what you got to do. Call ALS, don't call ALS, treat the patient, wait for ALS, whatever the case may be, just...
And I think
do your best.
Going along with that is trusting, again, when not to do something.
Mm-hmm.
Yeah.
Sitting there and going, do they really need me to, do an IV? Do they really need me to give them this medication? Can I treat this respiratory call with all oral medications? Maybe they have terrible pipes, or they say, yeah, no, sorry, you're not stabbing me. I'll let the hospital stab me, but you're not doing it in the back of a moving ambulance. That happens a lot.
They will totally say that. But my other advice to everybody listening is don't do your treatment based on what you think the hospital is going to do. I can't tell you how many times I get a report and they're like, oh, well, I didn't start a line because then you can't draw labs. I don't know where you're getting that from, but don't limit your interventions because of mine.
Right.
Different. Two different worlds.
Right.
Do what you got to do.
Yeah.
And
I would just say that along with the past experience, being a big driving force in the decision making process, good assessment, being able to assess the situation, assess your patient properly, that's going to play a key role in whether or not you're going to make the right choice to for intervention of what you're going to do or what you're not going to do.
Well, and
one thing I always tell the new EMT students that we have is, assess your patient, make your decision, and then have the testicular fortitude to live with it.
Mm-hmm.
Plain and simple, because there are times when it's better to just sit on your hands, but in those times when you have to do something, being paralyzed because you're not confident in what you're doing, or confident in that you've assessed this patient properly, that the difference between anaphylactic shock and hemorrhoids. I mean, you know what I mean? It's if you don't have that level of confidence, then you're gonna freeze, and that's
not what your patient needs right then.
Right, and that's it.
The patient needs.
While you look dumb, you are literally allowing them to get worse.
Yeah.
So. Yeah, it all comes down to, if you're bad at assessments, do more. Right?
Absolutely.
If your partner does all of them, push them out of the way. Talk to them before the shift to be like, yo, you did every assessment for the last 6 shifts. You're not touching a patient today.
Right.
I'm doing all the charts. I'm writing everything in. And they're going to go, oh, I got to drive for today? Fuck yeah, I'll do that. Yeah. All right, Miss Daisy, let's go. Right? That's what I would do. Yep. So, don't be afraid to sit there and be like, hey, I need to get better. This is a weak spot of mine. We are horrible at admitting that we are bad at things.
And that literally, as soon as you said that, all I could think about, I knew my college education would actually come in handy one day.
No.
All I thought about was Shakespeare.
That is not where I thought you were
no,
going
me
with
either.
This, above all, to thine own self be true.
Mm-hmm. Yep.
If you can't be true to yourself and know that, hey, you know what? I suck at this. I should probably get more practice.
Yeah.
No one's going to be good at everything. No one's going to know everything.
Yeah.
And you know what? I say it all the time to, my boys. I say it to students that you and I have taught. I've said it to partners that I've had. If someone berates you, makes fun of you, hates your guts, whatever it may be in the negative fashion towards you trying to learn and improve because you don't know enough and they know more, they need a swift kick in the dome because they are the problem. Yeah. You're trying to better yourself. Don't ever make fun of someone who's trying to learn. Don't ever make fun of somebody who's trying to get better at this job. I hate the old crusty son of a bitches that sit there and go, oh, you're the new guy? Yeah, go fuck yourself. And then haze them and don't teach them anything. Right? How are we going to get better as a profession if that's what we do? Right? I hate that. Yeah. Take them and nurture them and be like, listen, I'm going to make you better. Right? You're doing that with your new partner.
And it's going to go roll downhill. Yeah, absolutely.
He's already got the mold.
Yep.
Now it just needs to be molded into something really nice.
And without a fire pager on his head.
And without a fire pager.
It's going to end in the toilet. That pager will be in the toilet. I'm telling you.
You're nicer than I am because I said it's going to end up in his ass. but no, and that's absolutely right because if we do take the new people and treat them well, those that are deserving, because we all know there are some people that you just cannot fix, and they'll eventually just
go away anyway.
Yeah,
hopefully
they'll wither and blow away. But
Mike Kimmock dead fish theory.
Hopefully
they'll go somewhere.
Yeah. Commercially a mess.
I was just going to say that right now, you guys. Just going to say that.
But yeah, it's going to roll downhill because they're going to be like, hey, my experience when I was brand spanking new was really freaking cool. This cool paramedic took me in, showed me the ALS stuff, taught me how to do all this cool stuff.
And you want to create providers that you would let take care of your family. I don't want some silly person that thinks they know everything take care of my husband or my family. No, I want...
Yeah. And then when it's their time to be, the old crusty sumbitch that, doesn't tie his shoes and, his, third day in his
Don't get me
pants,
started. Don't get me started. I'll get on my soapbox.
And we all know them. We've seen them. We work with them. We love them. And,
maybe you do.
My point is, when it's their turn to be in that role, they're going to remember because law of primacy, things first learned are best remembered. Mm-hmm. They're going to remember when they were brand spanking new and shiny and eager to save lives, and we're going to change the world and make a difference. And
you sound like it's a bad thing.
Tell me how you really feel.
The sarcasm just exuding from my pores. But no, they're going to remember that hey, this cool cat Mike Turek took me under his wing and really showed me all this cool stuff. So you know what, you're my new EMT. I've been a paramedic now for a couple of years. I'm gonna do the same thing for you.
Yep.
This is what I do with mine. I had my paramedic interns my first batch of paramedic interns that I rode with, and I did for them, what it was done for me. We have, as our regular listeners will know, our Kelsey the intern.
Kelsey the intern.
She is an EMT intern, and I did for her the other day what a paramedic did for me as a brand new EMT. Said, hey, have you ever been in the ALS bag? No. Well, let's look.
Yep.
And we went through the
let's
whole damn
learn.
thing. Yep.
Yep. And it's never too late to start. Even if you have a provider that you think is slightly weak or could use some help, and they've been doing it for 15 years, be like, hey, let's do some stuff. Let's talk about stuff. Give them the opportunity.
Yeah.
Because nobody wants to suck. I mean, there are certain people out there,
even though we all do,
that really try to suck at this job. And
some of them have
succeed.
no problem trying. They just do.
Right. That's it. And those are the people that I wish that, you could approach and be like, hey, let's work on some stuff. Not saying that I'm perfect, right? We've all established that
we all suck.
We, do things that sometimes bite us in the butt, right? But we learn from them and we grow from them. So, guys, thank you for joining me. Everybody, stay safe, and we will see you next month.
Donuts.
Time, you too.
Thank you for taking time to listen to the Medic Materials Podcast. If you got anything out of today's episode, be sure to follow the podcast. If you want to be a part of our daily EMS discussions, join the Medic Materials EMS Education Group on Facebook. And be sure to watch our weekly instructional videos on the Medic Materials YouTube channel.